Have you ever had your health insurance deny a treatment that your doctor says that you need? You're not alone. But there is good news, which is that people who appeal often win. So today you're going to hear a little bit about prior authorization policy, but also how to succeed if you need to file an appeal. Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of UConn Health. David, this whole prior authorization thing is really a cover phrase for a lot of managed care techniques, and it's folks don't really understand what it is and why it's there. Maybe you could sort of explain it, because what is prior authorization?
Well, John, just as I'm thinking about it, I'm actually thinking the term may be actually redundant, because it's going to get authorized to do something, or it's going to get authorized prior to doing something. So it's a term, John, which says, okay, insurance gives you certain benefits, but then to use some of them, you need to get prior authorization. You need to ask for permission and make sure that it's allowed. And it's really done for the insurers to try to control spending. So let's say they don't want you to do something expensive without having to jump through some hoops to do it.
Yeah, I mean, I think that it's ironic that it's prior authorization when if you need a prior authorization, they're probably looking to deny it. So it's that I think is but you know, it was a reasonable concept when the health management organizations, the original health management organizations were created to reduce costs, to kind of help create healthcare on a budget, to move away from indemnity care, where they historically paid for everything. They used the ability to channel decisions around very expensive medical procedures like organ transplants, experimental therapies around for people who were really sick, to determine whether they were medically necessary and clinically appropriate and would be honestly worth the ROI. I mean, the classic example being someone who continues to get chemo, who's in a dire terminal state, where you're costing the health plan money and putting the patient through an unnecessary amount of pain and suffering that could be avoided. It proliferated in the 70s into the 80s and 90s as managed care organizations realized that the more, whether intentionally or unintentionally, the more hoops you put out that doctors and patients had to jump through, the lower the cost trend. And so it started to pop into things like basic specialty referrals, where your internist it's to refer something out, or diagnostic tests, or services that the plan might have not liked because they were expensive, but the patient or the employer actually needed. And then that's created a lot of friction and probably adds pretty materially to the administrative costs that represent the 20% excess administrative costs that we in the US pay versus other systems around the world. So prior authorizations are a very big deal, but they've also been historically a black box. And so maybe you could unpack, given for patients, employers, and payers today, what's the state of play, and like how would what's the patient path to actually get the authorization that they need to get the care they deserve.
Well, that's right, John. You know, it used to be a kind of the exception, and now it's more of the overall flow. It has evolved. I remember we talked about like electronic prior auth. So it went from faxes, where you're literally filling out, paper and faxing it in, to more of an electronic version of that, the same way a claim might be submitted electronically. But basically, this happens often in a time where someone's sick and needs something, and there's some time sensitivity to it. And so in addition to it being costly for the provider, which is clearly measured and results in, extra staff cost through labor costs, it's expensive to the patient as well, because they have to take a lot of their time often to deal with it and the stress of it. But the current flow is usually sort of like electronic versions of faxes. Now, what's coming in with this more technology, nobody actually wants to look at anything on either side. So there's more of a kind of a robotic approach as well, especially on the side that's receiving the prior authorization request.
Just to strip it down, what the managed care company will want is more clinical detail. And and ideally on the managed care side, they've then got an algorithm or a logic, usually overseen by a clinician, but not always, to resolve the question, the challenge, the more data, and the response to get the patient the care they need. Historically, when prior auth started, it was all physician to physician consult, and then it became physician or physician staff to nurse, and now it's gone from physician data to managed care algorithm, to your point. But there's still plenty of faxes, and it is a clumsy, time-consuming process. And to your point, from a patient perspective, it's a black box. And so if you're a patient that's being required to or told that, hey, a service or a referral or a drug is delayed until it's authorized, I mean, what's a patient supposed to do?
Yeah. So usually in my family, people call me and say, "What am I supposed to do?" So, what can you tell them? So
I can tell them that that's a bad idea, David.
Yeah, that's a
they should just call somebody else.
So you call 911, right? Hang up and call 911. So one of the things to do, John, is actually to work with your medical provider. So a physician's office, so you'll get something and say, you need prior authorization for this drug. I've had this, with my family. And physician office usually may have a care manager, for example. So if you actually work with them, they can help to put together whatever information you need, because they were the ones, the physician's office is the one that wrote this prescription in the first place or ordered this treatment. So they've got a rationale for it. And you've got people within the office that can potentially help you. Another one, John, is the same sort of general information that you would give as a recommendation to somebody dealing with any kind of bureaucracy, which is to be very organized, keep a record of everybody that you spoke with, what their name is, ask for a case number when you speak with them. Not so different, John, than if facing like an IRS audit or a request. Get your act together, get all your ducks in a row, and it's going to be more efficient, but also you're going to be more effective because you may have to be the glue that ties together the systems. I have some more, John, but if you have thoughts on those.
Well, no, I would just say from a patient perspective, I think that one of the secrets of getting a prior auth approved is staying very close to your point with the doctor, getting to know the doctor's office staff, not just the doctor or the nurse practitioner who's seeing you, but the person who's actually trying to clear this claim. They're as interested in making sure you get what you want typically as you are, and they know all the medical lingo and all of the requirements. And so while it's ideal if you get into kind of the detail of case numbers and appeals and all that stuff, and the reason why it's worth pushing for the care you deserve is, well, for example, in the case of Medicare, where a lot of these prior authorizations are in place, 82% of the appeals against denials. So let's say the process works, you're authorized for service, all good to go. The prior authorization really only comes up if you are denied or deferred service. And then you always have some element of a route to appeal. And what you should think about is 82% of the appeals on denials are overturned through the appeal. So I just think that's something to think about, which is why the people shouldn't get care delayed or denied just because they don't feel the energy or they think that perhaps the system, is making a sensible choice. If your doctor or your clinician thinks you need something, you should push to get that need. And it is increasingly a challenge for doctors and doctors' offices. And they are very much organized to help. Patients need to lean in. But you should also realize that vast majority of these denials, when it actually is denied, are actually overturned on appeal when a more senior clinician sees it, or there's more data provided that makes a more compelling case. So if your care is denied under a prior authorization, one of the dirty little secrets is you should push to have it appealed.
Yeah. John, you're right. I mean, this is an example when we talk about, hurdles to jump over, hoops to jump through. This is kind of what we're saying, that at the end of it, if you actually do that, at the end of the day, they're going to say, oh yeah, that shouldn't have been denied in the first place. And you can see that the kind of administrative burdens are put up there. Now, that's not to say that all of the prior authorization denials are wrong. And we don't know, those that weren't appealed, which would have been overturned and which wouldn't. But if you have...
Well, and as a practical matter, David, like some of the formulary requests to try less invasive or expensive therapies, less dangerous therapies before you, let's say, get a more expensive drug that might have more side effects, those are reasonable, like, going through a particular formulary drug, going to the less expensive drug versus the more expensive drug when it's this same chemical compound. I mean, there are reasonable reasons for prior authorization and working off of what, PBM or physician pharmacy benefit managers calls formularies, where they try to get you to the less expensive drug, that are all oriented towards making sure you're getting the care you need at a cost you can afford. But where you've got a treatment, a service, or a drug that you and the doctor are convinced you need, you should definitely get in that appeal queue as quickly as possible, because the health plans are responsive, and they need to and they historically have been responded largely on the patient's side.
John, you cited this Medicare Advantage with the 82% of denials being overturned, and that actually points to a tip, which is to make sure you understand your insurance. So if you have Medicare Advantage, it's actually fairly likely through this appeal process it will be overturned. Medicaid a little bit less generous, so more like a third of appeals are overturned.
Well, but in Medicaid, many of the services are already provided, so that right. It's a little bit of a looser benefit and a more expansive one. So that makes sense.
Fair enough. Now, John, but another interesting angle that a lot of people don't think about is that we talk a lot about employer-sponsored health insurance, right? So the health insurer is often working for the employer. And this is even used to be just very big companies that would be self-insured. Now it's much smaller ones also. Now they outsource the administration of that plan in general to somebody, but they retain the ultimate decision-making. So if you think about employer-sponsored and something is being denied, it's ultimately the decision-maker is the employer if they're going to pay for something or not. So it can make sense to actually go to your HR department in certain circumstances for something expensive and say, look, can you help me out here? And they're the ones deciding whether to pay or not, ultimately.
Well, that's a really good point, David. I mean, if I had an expensive, I think this is where patient engagement and leadership is absolutely critical. You and your family need to first partner with the physician office and the staff that's really working this. But the second thing you should work with is your HR, your human resources and employee benefits departments, because they are often as motivated as you are to make sure you get the care they need. And in some cases, the health plans will move a little bit faster if someone someone who's buying the health insurance for them, the employer, makes the call. Yeah, no, I think that's a really good point.
Yeah. John, I know less about this. Maybe you have some more insight into it, but at the state level, there are advocacy programs, typically free assistance programs, and there's some nonprofit organizations as well that can actually help. If your doctor's not helping, or if you're not have employer-sponsored insurance.
I mean, we're really talking about the dirty secrets of how you can work the denial process to get the authorization for the prior authorization that you need. And so it first starts with working with the doctor's office. The second place to work is through your employer. The third are state and local organizations. And to your point, it does vary by state. In some cases, the Attorney General's office have been involved in some of these questions and concerns, particularly if there's a pattern of denial that they're skeptical of. In other cases, there are state sponsored advocates whose job is for people with really complex illness who are having a hard time advocating for themselves, working with them. But I think, and then there's some nonprofits, to your point. But I think that you kind of want to, for a vulnerable patient with a chronic condition that needs care and believes they're not getting the care they need, I think you want to be pushing forward on all fronts.
John, I have had success in the past working with a dependent who was at school out of state. And there was this, not exactly prior authorization, but like a coordination of benefits issue. And it was sort of getting, everyone saying, not my problem. It was, I'll tell you, it was in a Western state. And my plan was in Massachusetts. And it was sort of like everyone was pointing fingers. And I contacted the insurance regulator in that Western state. And it was resolved, in a week, because they regulate the health plan. And they told the health plan basically get on it. And it was just a whole different department, right? You're outside of customer service into compliance and government relations.
I think that's brilliant. I mean, but you're going to be more creative. I think we want to create a simple plan for patients that are trying to navigate this dark
Okay.
maze of health insurance. And so, if you can get to the regulator, but again, I would almost prioritize doctor's office, um, employer, keep good records, and then start looking for state agencies. Yeah, if you can get to the regulator, Dave, you really. But
Okay.
I mean, again, you're a persistent nerd, so
Fine, John.
you're more creative than most.
I got a every person solution I want to ask your opinion about, John. Social
Sure.
media. Social media. Should I complain on Facebook? Should I
I see
tag him on LinkedIn?
I see no downside to that, Dave. I don't like the public shaming thing in general. And you've seen that in some cases, health insurers have gone after people for defaming them. I don't know how effective that is, given the fact that in general, the patients are telling their own stories. But I think if you go down that route, which I'm not a big fan of, but has shown some success, you want to make sure you're absolutely factual and you're absolutely right. Look, big companies make mistakes all day long. Small companies do too. When it's your family and you're the patient, you want to fire all the ammunition you've got to make your case. But I just think social media people have a tendency to go a little bit over the top, and so I'd be probably more careful on that one. And if you go down that road, I'd be I just really stick to the facts.
John, here's the approach that I've used with some success there. It's actually to go on LinkedIn and just to tag the company and just say, I'm having challenges, despite a lot of effort, I'm having challenges with prior authorization, can't get someone to speak with me. And it will get picked up by that social media team, which is a different team than if you call or write to them, and they may have a different channel. And so it's just a way of getting through the bureaucracy.
It's a great point that if you're appropriate and polite and specific, LinkedIn, I think, is a really good vehicle to get the attention of people who can make decisions and help the patients.
John, let's talk about AI a little bit, because I do believe it's relevant here. Anything you've got all this kind of paperwork going back and forth, all sorts of nonsense, it would seem that AI is going to have a place. And it seems like it's unclear to me, is it an arms race between the provider and the payer? Is it a way of smoothing things? Where do we go from? Where's the current state, and where do we go from here?
Well, there's definitely an arms race happening. And it is health insurers are looking to file, if not close to double digit price increases, because their trends are showing, their cost trends are showing that's going to be required for them to maintain the balance sheet and that's profitable. And that's going to create some sticker shock. In order to tamp down those trends, I think you're seeing, at least anecdotally, a much larger number of denials and new policies associated with keeping those trends, those higher cost trends down. So the payers are investing in technology to look for places where they can defer, deny, or avoid care. You've got patients and patient advocates, and particularly on the physician side, who are trying to do the right thing for patients, and hospitals submitting these bills. And they're also investing in technology to get more cash to them paid faster, more appropriate services covered and compensated for. And so you see investments in advanced technology on both sides, in the electronic medical record field, in the revenue cycle field, as well as in payer systems. So I do think you are currently got an arms race. I think that can be a little bit of a distraction. Both sides are blaming AI. I do think we've got a sicker and more complex patient mix that's costing more. You've got the erosion of the ACA subsidies, and a lot of people very vulnerable people being thrown off of Medicaid soon, as well as a continuing erosion of the economy, particularly for the poor and the lower middle class, because costs continue to rise. That means people are deferring care until they get really sick. Yeah, my hypothesis. So I do think the core things that are driving making people sicker and driving costs up is really what's going on. But both sides are investing in artificial intelligence. But what's interesting, David, is that I do think this administration particularly Commissioner CMS, Administrator CMS Mehmet Oz, Dr. Oz is really trying to leverage technology to lower those points of friction. As a former cardiac surgeon, he feels very much the burden of having had to clear all of those prior authorizations for really sick folks with heart disease. And I think he's starting to broker, if not peace, at least practicality between the health plans and the technology providers and some of the physician organizations to come up with ways that, look, you can keep your prior authorizations, but it's going to be automated, simpler, and it's going to cover fewer of the more expensive categories so that it's less of a burden for everyone who's trying to get more expensive care. It's only appropriately applied to where it's going to improve care and avoid unnecessary care. And so I do think there's the bad news about AI is right now it's just, I think, going to add to more administrative friction in the short term. But this administration is actually trying to broker some innovative policies to solve for that, and which would hopefully lead to lower physician and patient burden and faster compensation for docs and hospitals. And that's the hope, at least, because with technology, you should be able to get there faster, simpler, and cheaper.
John, I like ending it on a positive, but I also believe realistic note. I think with Congress essentially sidelined, the executive branch taking a bigger role, it's good if you've got somebody like Dr. Oz who actually sees this as a priority and understands it well enough, not just from the kind of payer standpoint, which CMS is, but also from the provider side. That coupled with technology, gives us some reason to be hopeful and at least put some pressure in that direction. Well, that's it for yet another episode of CareTalk. We've been talking about prior authorization and related factors. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of UConn Health. If you liked what you heard or you didn't, we'd love you to subscribe on your favorite service.